In this video, we're going to go through whether or not a labral tear in the hip can be managed by exercise alone. So we're going to dive into it and talk through that now. Now, the hip labrum is something that often gets injured. It's something that you'll come across loads, especially if you're either a young, active individual or a clinician that treats young, active adults. But it can be absolutely demonized, both by patients and also by clinicians. Demonized because of the fact that it's referred to as a tear and it's something that can cause hip pain, but also it's not necessarily a structure that on its own can heal. So I want to dive into it a little bit more in this video, just to understand where conservative management lies with those people who have hip labral tears, really how successful it can be, what it needs to embody, what it needs to do. So we're going to dive into that now. But first, we've got to figure out what even the labrum is, right? Because you'll hear the term labrum and you might not even know what it is. So let me just kind of like paint a real simple picture. Now you've got a ball and socket. Now the socket has something called the labrum that sits on the top of it. And this makes the hip suction, that gives that suction pressure of the ball in the socket. It covers it, it kind of like makes the depth a little bit greater, and it gives the joint that increased congruency that it needs. But it plays a really vital role in general joint health and joint stability. Now, unfortunately, in some cases, people can develop a labral tear, and there are certain things that can contribute towards it. And I would kind of classify that in regards to hip conditions and also things like trauma, that can also occur and cause a tear. But the thing is, it's the way that these things contribute to a labrum tearing and also understanding how the symptoms present that are really, really key. Now, we've got a couple of things here to consider, right? Let's talk about the type of hip conditions that could contribute towards a labral tear. You've got something called hip impingement or FAI syndrome, and you've got something called hip dysplasia. These two things are very different. On one hand, you've got hip impingement, which is often either an overcoverage of the ball from the socket covering it more, or something called a cam morphology, which is like a little bump on the femoral neck, which is the kind of the neck part of your thigh bone. That in one aspect could contribute to someone getting a labral tear. On the other hand, you've got something called hip dysplasia. In its truest sense, this is a shallow socket. Now, when you have a shallow socket, that could then mean that the capsule or the ligaments around the hip joint, they're having to do too much. And like with most things, no one really likes to do too much excess work, but that's what they have to do. The labrum, the ligament, gets pulled into doing too much. And after a period of time, it just can't tolerate it. And you get what's called like an instability type presentation. And that, as a result, can sometimes mean that the labrum has to do too much. It's doing its job and then some. And then that can lead to a tear. Now, these two things are very different, but the outcome could still be arguably the same thing that gets damaged, which is the labrum. So then we've got to figure out, well, we've got there's almost like two skeletal things here, like morphology, skeletal drivers to how it can develop. So how are we as physios and clinicians going to make a dent on that when structurally there's something there that has driven it? So let's have a little think. What does an actual labral tear look like? How does it present? What are the features of it? Now, firstly, most things that involve the hip joint often, and this isn't an exclusive, this isn't like 100% of the time, but a lot of the time the symptoms will be around the front of the hip. This kind of C-sign type pain that you can get, or groin type pain that you can get, is often a hallmark of someone that has what's referred to as an intra-articular issue or a hip joint component to it. And this is the same with the labrum. Patients will often say it feels, sometimes it might even start as a bit of tightness, or it might feel like it's a bit of a tight groin. But the labrum itself will often present with those features. And then you've got to think about the things that might aggravate it. And it could be things that include like cutting-based sports or pivoting, sitting, driving, sitting cross-legged, putting shoes and socks on, anything that really is using the hip into a flex type position, and that's where you're bringing your knee up towards your chest, or rotating type position, or even combination of all of these things together often can produce those kind of symptoms that will elicit not only the pain that they've got, but it will exacerbate that further as well. And in some instances, it might even refer a little bit further down the thigh, but it certainly doesn't really go too much further than that medial or inner part of your thigh you're not going to get labral pain that's referring into like your Achilles or your heel or something like that. But these things can sometimes be a slow burner. Remember those two conditions I said to you about, hip impingement and hip dysplasia? These things are slow, gradual, progressive. People have these conditions for a long period of time, and as a result, those labral tears or labral injuries are slow and gradual, which means that the onset is sometimes quite a long process. Patients often don't really know what's going on, and as a result, they have symptoms and symptoms and symptoms that progress and progress and progress, and sometimes are mistreated or misdiagnosed, inadvertently. But some of the things that you might often hear and see are things like hip flexor tightness or hip flexor weakness, hip flexor tendinopathy. And to be honest, labral tears, like I said, they're not exclusively always going to be groin pain. You might even get someone that presents with pain around the side of the hip or the buttock. And in those instances, they may also get misdiagnosed for bursitis, for piriformis syndrome or other kind of things that cause buttock pain. But nonetheless, we're here to talk about the labrum today. Now, the difficulty when it comes to this is also trying to diagnose it, because a lot of the time, the gold standard for this is MRIs. MRIs are the machines that you go in, little tunnel, and you lie there and you've got to kind of not move for a while, and loud noises. I mean, that sounds really precious describing it like that, but you know what I mean. The tunnel, you go in there and it looks at the structures within the hip, looks at all of these different bone and soft tissue type structures, and it shows us if there is a labral tear. Now, sometimes as a patient, you might get that report and look at it and think, geez, sounds pretty bad. I've got this kind of like inner capsule tear of my hip. What am I going to do? But to be honest, sometimes these things come up and they're normal. It's almost like 50% of the time. You could have no pain and you could be watching this, although arguably not many people go searching for hip content unless you have hip pain. But nonetheless, you could have no hip pain and have a labral tear and not know about it. So what you find on the imaging is one thing. It's about linking it up to your clinical presentation and seeing if it's relevant or not. That's the other thing. But nonetheless, if you're suspecting someone has a labral tear, you go for an MRI and you'll have a look at that. And then you kind of would take it at face value. I've got a labral tear. What am I going to do now? And then the age-old question comes to light. You try some physio. Try and go to do some physio, because arguably your first port of call is not going to be, I tell you what, book me in for surgery, get me on that operating bed, because I don't know anyone that wants that as their first choice. So you try some physio. You go over to your physio and you start the physio. And I've had the question asked many a time before. And the question is a warranted one. And the question is, how is physio going to fix this? I've got a tear in the hip joint, and that's a tear that's not going to heal itself. So what's the physio going to look like? How is it going to make my symptoms any better? But then you've got to remember what we've just discussed, the fact that these processes that could have contributed to the tear have been slow, have been gradual. It's almost like the tear has been as an effect of other factors that have contributed towards it. A lot of the time patients have these tears and have no pain, which means that there is an abundance of tolerance level that these hips can tolerate with a tear. So the focus of your clinician should be that. The focus on your clinician also should be on almost two things at this stage. Building physical resilience through exercise, through rehab. Trying to enable the hip to do the things that it needs to do. Trying to enable the hip to tolerate activity, to tolerate exercise, movements, positions, all the things that over a period of time have become more tricky, a bit more difficult to tolerate. And that is the skill of the individual. That's the skill of the clinician to identify what exercises they can do and also what your needs are. Because someone who has a labral tear, you could have 10 people with labral tears of the hip. The way that it behaves, the places that they have muscle weakness, their stability, their levels will differ. It's not going to be the same every time, even though on paper, they've got the same thing. And that's why exercise selection is key, because not only are you going to be doing things to physically get them more resilient and build up the strength of the hip, build up the stability of the hip, you've got someone there that you are treating. So you're treating a person, you're treating someone who has a labral tear. John, Jane, Chris, Mehmet, Fatima, whoever it might be. You're treating someone who has hip pain, not just a labral tear, which means you're dealing with an individual. And these things up here, the brain, is fairly complicated. So then you've got to build the psychophysical resilience and the psychological resilience. Look, I let it slip there. I was too excited to talk about it, so I let it sneak into my prior point. But psychological resilience is key. Think about that. You've got pain for that period of time. What's going to happen? You're going to become a bit fearful to use it. You're going to become a bit anxious to use it. So your psychological resilience will increase the more your physical resilience improves, because you'll do the exercises, you'll feel better, you'll feel stronger, and before long you'll think, actually I'm able to do those things that I couldn't do before, but I've still got this labral tear. And don't get me wrong, guys, look, there is going to be a situation where sometimes people don't get better, and I'm not here to paint a tainted picture. I'm here to paint a pragmatic and be very transparent that majority of the time, loads of people can benefit and do successful rehab without the need for surgery, without the need for anything else. But we have a group of individuals sometimes that for whatever reason, things don't tick over like we want them to. We get to a point of where patients are still struggling. They've done the rehab, they have been diligent, they have seen the best physios, they're trying to do all the things that they can do, but things aren't improving. And at that point, you still have to figure out, fine, well, we've had the MRI, that's given us some information about a structure that could be causing that person's hip pain. But then I said to you, not too long ago in this video, that some people have labral tears and have no hip pain. So imagine I was your patient. Imagine I'm the patient and I've come into the room and I've got an MRI that says labral tear. I've gone for physio, tried the physio, and it's not worked. And then you're back with your surgeon, back with your doctor. And the question comes up, how do you know it's my labrum? Well, you don't, because nothing's proven that yet. And that's why when the physio isn't working and things aren't progressing like you want them to, that first port of call, that first little bit of due diligence, before you even consider surgery or anything else, is doing a diagnostic injection. Because if you have a diagnostic injection into the hip, into the labrum, and the pain goes, that's your ace in the hole. That's your kicker. That tells you at that point, actually, the structure that I thought could be painful must be the painful source, because you've had a diagnostic injection. And don't get me wrong, you get the therapeutic benefit of it. You get the kind of like resolution for a short term that you've been craving. But is that the answer? Is that the long-term resolution to your pain? Is that going to be enough for us to be satisfied that we've done enough to really exhaust all of our options? And actually it does paint a bit of a picture, because at that stage we've got a pain-free hip. We've got a little bit more understanding that this labral tear that we had or suspected or that had been shown up on the MRI is the thing that's causing the pain. And you're satisfied that you've done as much rehab as possible. Now, even at that point there, you still don't know whether it's hip impingement or hip dysplasia that has caused it. Because all we're doing now at this point, all we're talking about is the effect. We're talking about the effect of something that's been caused but by a cause that we're not really too sure yet. So there's a lot of due diligence that needs to go into doing things way before you do any surgery. And you've got to think, you could have had that MRI scan, seen the labral tear and gone straight for surgery and not considered any of these factors. So the exercise always is going to trump, is always going to be key. And look, I'm a physio. My bias is always movement, is always exercise. And when a hip is painful and when it has sharp pain and it feels like it's giving way and it deconditions and it weakens over a period of time, exercises aren't just about trying to make the hip joint stronger. Exercises aren't just about trying to make your glutes stronger or your adductors a bit more mobile or increasing your hip mobility. The focus is around considering that you've got an individual in front of you who has hip pain, and your treatment and your rehab and your exercises, for sure, they might not necessarily make that labrum heal. They might not make your labral tear resolve itself physically, but it certainly can help that individual feel a bit more psychologically resilient by making them more physically resilient.